On-the-scene video coverage of TCT 2012 is supported by Pradaxa.
Ladies and gentlemen, I have the privilege on behalf of the authors to present for the first time the results of the ISAR-LEFT main... Oh. And now? Okay. Perfect. Okay. Of the ISAR-LEFT main 2 trial, which is randomized trial including only consecutive patients with unprotected left main coronary artery disease. It's already known, and there is a large body of scientific evidence showing that the risk of death or myocardial infarction between PCI and CABG for unprotected left main coronary artery disease is very similar, even at long-term follow-up. However, after PCI for unprotected left main coronary artery disease, the risk of repeat revascularization is 2 to 3 times higher than after CABG surgery. That's why we are looking for a drug-eluting stent which has the best performance in this patient. In the subset of the ISAR-LEFT main, the first one trial, we compared the first generation of drug-eluting stents for patients with unprotected left main coronary artery disease. And the Taxus stent and Cypher stent were compared, and there was no difference regarding to death, myocardial infarction, or the intervention in these patients. So the first generation drug-eluting stents, we know that the Taxus is inferior to Cypher regarding high complex lesions or high complex subset of patients. However, for unprotected left main coronary artery disease, there was no difference between both stents. The second generation drug-eluting stents have been shown to be superior to first generation. With the Zion stent, we have the example that at 4 years follow-up, there is a 20% reduction of target vessel revascularization compared to Cypher, 50% reduction of late definite stent thrombosis. And there is the Precombat 2 trial has shown that the Zion stents probably it's better than the Cypher stent even in unprotected left main coronary artery disease. Another stent of the second generation compared with Science was the Resolute stent, and in the Resolute all-comers trial there was no difference regarding target lesion failure and target lesion revascularization. But the percentage of patients undergoing intervention for unprotected left main coronary artery disease in Resolute all-comers was only 2%. That's why we designed the ISAR-LEFT main 2 trial, in this 4-center trial with 3 centers in Germany and 1 in Italy. The aim was to compare the Endeavor Resolute stent with Science stent in patients with unprotected left main coronary artery lesions. It's study powered for clinical endpoint, primary endpoint, major adverse cardiac events, composite of all-cause death, myocardial infarction, target lesion revascularization at 1 year. Secondary endpoints, safety endpoint, definite and probable stent thrombosis at 1 year, and efficacy endpoint, angiographic restenosis at 9-month follow-up angiography. We hypothesized that the Endeavor Resolute stent is non-inferior to Zion stent regarding the primary endpoint. 650 patients with unprotected left main coronary artery lesions were randomized. Key exclusion criteria were cardiogenic shock, S elevation myocardial infarction, or instant restenosis within the left main area. Half of the patients received Resolute stent and half of them Zion stent, 70% angiographic follow-up at 8 months in mean, and 100% clinical follow-up at 1 year. Patients with unprotected left main coronary artery disease are high-risk patients, mean age 70, a quarter of them being women, 30% diabetes, 30% history of MI, a high Parsonet score of 13 in mean. Also, 70% of these patients have already multivessel disease, and which is important in the ISAR-LEFT main 2 trial, we have 80% of the lesion located in the distal part of the left main coronary artery area, which means a high risk for restenosis. However, the single stenting technique was used in 65% of the patients. Now, the primary endpoint results at 1 year, no difference according to MACE rate, 70% with Resolute, 14% with the Science stent. We were able to show the non-inferiority of the Endeavor Resolute compared to the Science stent regarding MACE in these patients. According to the stent thrombosis, we have a very low stent thrombosis rate, 0.6% definite stent thrombosis with both stents, and just one patient dying suddenly within 30 days in the Resolute arm. However, the numbers are very small to show any conclusive results. the restenosis in the left main coronary area, which means not only in the left main, but also in the proximal part of the LAD and circumflex artery, 21% with the Resolute, 16% with the Zion stent, numerically different, but not statistically significant different. According to the revascularization, 12% for Resolute and 9% for the Zion stent. Important to mention is that only 1% of the patient were in need of bypass surgery within the first 1 year. So to summarize, this second-generation drug-eluting stent in unprotected left main coronary artery disease are safe and effective, and the clinical and angiographic performance of both Resolute and Science were very comparable. Thank you very much.
Thank you.
So
this paper is open for any questions from the press. Yes, please.
Cohen from angioplasty.org. I just wanted to clarify. This is the Endeavor stent because
Endeavor Resolute.
Because Resolute is also is used as that's a newer stent that is not the Endeavor Resolute stent.
No.
This is the Endeavor Resolute stent.
Resolute.
No, it was a little bit confusing. Today we differentiate the old Endeavor and the new Resolute, and this was the new Resolute.
This is the
Yes,
new
this is
Resolute.
the next generation
I would suggest
Resolute.
not to use the word Endeavor in this context.
Yeah.
Okay. So
Because the old Endeavor stent is not an excellent drug-eluting stent platform. He has a late loss of 0.7, so a very high restenosis rate. In these cases, we use the same stent which was used in Resolute all-comer study, is the new Endeavor Resolute stent with the BioLinks
Next
matrix.
question.
I'm Dharam Kumbani from Cardiosource. Quick question. Were these all patients with left main PCI only, or did they also have other vessel PCI?
Part of this patient had also other vessels PCI, but we included only patients that needed to have an intervention in left main coronary area. And nearly 20% of them needed also an intervention in the right coronary artery in the same during the index procedure or somewhere in the LAD or LCX. But all of them must to have need for intervention in the left main coronary area.
Can you then put your results in perspective for the Syntax trial, where the MACE rate at 1 year was also about 16%?
Yeah.
Because the TLR rates typically are better with the newer generation stents?
Sure. First, in the Syntax trial, we have to do with another population. We have not only unprotected left main disease, it was a general population, but the rate of the MACE rate for people in the subgroup of unprotected left main coronary artery disease, it was 15 or 16. It's similar with this one, but they consisted also the other arteries, the revascularization in the other arteries, not only in the left main area. And we have to admit that the characteristics of the left main population in the ISAR-LEFT main 2 is a very high-risk population. In the Syntax trial, we had only 60%, as I can remember. 60% were distal located lesions. We have 80% distally located lesions. And most of all, we had here patients who were 70 years old in age. In the Syntax trial, 65 years old. So it's a kind of different population. That's why we have similarities in the in MACE rates. But
So
if you
I think it would be great, actually, if you could give us the syntax or the clinical syntax score of these patients so that we could put it into perspective, one. And then secondly, I think a big difference that I saw, and I saw the curves actually behaving in that way, is that 6-month angiographic follow-up that you actually had in a lot of these patients, which could drive a higher revascularization. And you actually saw that the curve going up a little bit. So I think that does have something to do with driving those TLRs higher. We don't expect to see the same TLR numbers as the first generation DES with the second generation. So I think it's important to note that. But do you actually have some of the syntax or clinical syntax scores of these patients?
we haven't done this. No.
Okay, great.
It was not double blind, of course. Yeah.
No,
But this emphasizes what you said, the jump up with the follow-up angiography. If it's not double blind, you.
But however, if we compare this data with the ISAR-LEFT main trial in which we use the Taxus, we have an improvement in the target vessel revascularization in comparison with the ISAR-LEFT main trial. It are both the first one. And however, we have to admit we are doing now patients which are more complex, at least between the left main 1 and left main 2.
Lynn Peterson with Trends in Medicine. So this was a non-inferiority trial, and you met non-inferiority?
Yeah. But we didn't analyze any superiority. We just met the non-inferiority for the Endeavor-Resolute against the science standard.
Okay. Thank you so much, Julinda. Thank you again.